Welcome, everyone. The Washtenaw County Health Department and the Washtenaw County Medical Society are pleased to present this webinar as part of our 2021 Cannabis in Practice series. Visit the Cannabis in Practice webinar series webpage for updates, links, and to archived webinars and more. We will add the link to the chat box. And now I'd like to introduce today's speaker. Dr. LARA Borgelt is an Associate Vice Chancellor of Strategic Initiatives at the University of Colorado and professor in the departments of Clinical Pharmacy and Family Medicine. Dr. Borgelt's teaching, practice, and research focuses on patient safety and women's health. Her initial interest in educating providers and patients about medical cannabis started about 10 years ago when she was asked clinical questions about its use in pregnant and lactating women. Since that time, she has investigated the potential effectiveness and risks of cannabis in a comprehensive manner and has provided evidence-based presentations to medical, nursing, pharmacy, and patient organizations at the state and national level. She has served on 8 different working groups regarding rulemaking in the state of Colorado involving consumer safety and social issues. Through her training and experience, Dr. Borgelt has extensive knowledge of cannabis with regards to its pharmacology, pharmacokinetics, pharmacodynamics, therapeutic effectiveness, and potential risks. Her evidence-based balanced approach to identifying potential benefits and risks of cannabis is important to determine its appropriate use. Welcome back, Dr. Borgelt.
Thank you, Charles. And I have to say, you did a fantastic job pronouncing those extremely difficult pharmacology words. Well done.
You know, I practiced like 10 times, right?
Perfect. Perfect. It's such a pleasure to be here and to actually be back with this group. And for any of you who may have joined last year, I do have a few updates that I think you'll be interested in hearing about. And so I'm going to go ahead and share my screen and get the slideshow going for us here. Give me just one moment. And Charles, can you just confirm that you can see that okay?
Yes, Laura, we're
okay, great. Thank you so much. So today we're really going to be focusing on women at pregnancy, and I'll just have a little bit on lactation as well, and the use of medical cannabis. And I think I'll tell you about how I got into this space in just a minute, but I think it's important to recognize that this is becoming an increasingly important area for us to acknowledge as healthcare providers and really join our patients where they are at in the space and understand why they may be even considering use of cannabis while they are pregnant or breastfeeding. And so I don't have any disclosures, but clearly I am discussing an unapproved drug and its use. It's still a Schedule I drug according to the federal government. And so I have to disclose that. But as Charles mentioned, I've been a member of several different working groups in Colorado, which has really opened my eyes to the various lenses, I would say, that marijuana brings to the table. So by the end of this presentation for today, we're going to talk about the use of cannabis on the endocannabinoid system and fetal development. We will look at the studies that have evaluated the use of cannabis in pregnancy and lactation. And then at the end, I'm hoping to give you some real practical information about how we talk with patients, some of the opportunities, and maybe even some of the challenges there for having these conversations. And so I mentioned earlier about my story. I never intended to become an expert in medical cannabis. And this is a clinic where I have worked for many, many years, close to 20 years, actually. And in this clinic, it's interdisciplinary. And I work with a team here. You see a physician, nurse, a psychologist, and myself talking about a patient. And it was one very distinct day when we had a patient come into the precepting room here and tell us about a patient that was breastfeeding and smoking a joint per day. And in that moment, it wasn't the joint per day that was surprising to me, although obviously a joint per day seems like quite a bit when you're breastfeeding. It was that the medical resident had told the patient that that was completely fine. And it really made me question, I'm pretty sure that's wrong, but I don't know if it's right. And so it led me down this path of trying to find information about cannabis use in breastfeeding and in pregnancy. Very, very limited information was found, but I ended up coming back and reporting what little information I could find, recognizing that it appeared that there was some risks to its use, and reported that back to the physician, and he recommended me to give a talk at our state medical society meeting, and somehow then at that point I became the expert. And I really needed to make a decision at that point in time if that was really the expert I wanted to be. Up until this point, I had really focused on women's health and patient safety as two separate kind of entities. But all of a sudden, there was this opportunity to not only be a trusted source of information, but bring the expertise to the table that I had had in this space in a new and enriched way. And so here I am now presenting to you almost 10 years later to share some of the knowledge that I've been able to gain. And I certainly hope when we get to the Q&A, we'll be able to learn with each other, because I always learn when we do these presentations as well. And I'll start here with a patient case. This is a very typical patient actually that we see now in Colorado. 27-year-old female coming for a second trimester prenatal visit. She's taken a prenatal vitamin and she's not smoking, drinking tobacco or smoking tobacco, but she does smoke cannabis 1 to 2 times a day. And she initially started it to relieve her nausea in the first trimester, but now she continues it because she really feels like it improves her sleep. And she knows that there could be potential harm, but she doesn't think the studies were done well enough to make any real conclusions. And so for her, she feels like the benefits outweigh the risks. So the first question I think we can go through and ask here is, what effect could cannabis use have on this patient and the fetus? So this will address our first objective, which is discussing the use of cannabis on the endocannabinoid system and the development of the fetus. So by now, you probably are all very well aware that we have an endogenous endocannabinoid system. In our body, there is an endocannabinoid system that has endocannabinoids and endocannabinoid receptors that go literally from head to toe throughout our entire body, through our brain, through our connective tissues, the nervous system, the immune cells. It really is a full body system. And much like the nervous system, in every tissue and in every place, the cannabinoid system performs different tasks with the goal being homeostasis, meaning the endocannabinoid system wants to stay in balance. So it will produce endocannabinoids on demand. It will make receptors available to those endocannabinoids when they are produced to create a particular effect. And so we have CB1 receptors throughout our nervous system, connective tissues, gonads, glands, and organs, and CB2 receptors primarily in our immune system. There are some CB2 receptors in our gut as well. And the endocannabinoids that are produced are many. The two that we talk the most about are anandamide and 2-AG. But keep in mind that we have many more endocannabinoids that are produced in the system, and that's another talk for another day. But these are the two that have been discussed the most in the literature. Now, this baseline is really important because while our body is producing anandamide, you can see here that the chemical structure of THC is extremely similar. In fact, this exogenous cannabinoid, or a cannabinoid coming from the plant and from outside the body, THC, is hundreds to thousands times more potent than our body's anandamide. And this becomes so critically important because as we think about a developing fetus trying to generate its own endocannabinoid system, an extremely potent exogenous cannabinoid could have an effect on that system. And in fact, that's what we see potentially happening. So the cannabis plant, this exogenous plant, has over 100 different cannabinoids. You're all very familiar with THC and CBD. There are also CBN and CBC and CBG. The plant also has a variety of terpenes and terpenoids, which give the plant its smell. Flavonoids, sterols, thiols, phenols are parts of any plant. And I want to mention specifically that cannabis is a very lipid or waxy plant, which means that it's lipophilic. And the reason that this is important is because it reminds us that, especially in pregnancy and lactation, that cannabis can readily pass through not only the blood-brain barrier, but also the placental barrier, and it can be excreted through the breast milk as well because of that lipophilicity. And so it makes it a really common place where cannabis could pass through to the fetus. As you all know, cannabis can also be a fibrous material, which hemp is commonly used for things like rope and purses and clothing and things like that. Now, I will say that almost all of our information in pregnancy and lactation comes from the study of THC. And it also comes from the study of THC in more of a recreational context than a medical context. And so those are just kind of important caveats to keep in mind. And we'll talk about that as we get into the studies. But I just wanted to remind you that most of the information we have right now is related to THC. Now, we know for the endocannabinoid system, this system is developing anywhere from 9 to 36 weeks gestation. Now, there are a few reports actually that will tell us that that system may be in development at 5 to 6 weeks. So very, very early. Most of the data supports 9 to 36 weeks. But as you can imagine, an exogenous cannabinoid such as THC could appear like a sledgehammer to the system if it's hundreds to thousands times more potent than our natural endocannabinoid system in development. There are a couple other really interesting things happening with regards to the endocannabinoid system as the fetus is developing. There are actually a much higher level of CB1 receptors in the fetal brain compared to the adult brain. So that creates a potential susceptibility to something like THC with having more receptors in that brain. There's also in this process a very specific role for the endocannabinoid system in key developmental events. So we know that the endocannabinoid system provides metabolic support. It helps with cell proliferation and migration. It helps in the neuroprotection for the CNS. It helps in axonal elongation, which is really important as the neurons are developing and growing and starting to communicate with each other. And that then leads us to synaptogenesis, which is when the neural fibers or the ends of the neurons are communicating back and forth. And of course, that's done with the use of neurotransmitters. So examples of key neurotransmitters would be things like serotonin and dopamine and norepinephrine, GABA, all of the neurotransmitters in our body. So this endocannabinoid system is helping our body develop these really key functions. The other thing that we see is that when we have cannabis exposure, so this is now kind of that exogenous piece, there's this potential for a supraphysiologic stimulation of that endogenous cannabinoid system. And what we see, especially throughout in animal models, is that it can disrupt endocannabinoid signaling. It can interfere with synaptogenesis and the formation of those synapses in the central nervous system. It can interfere with the development of these neuronal interconnections so that axon development and growth may be impaired. And then, as I mentioned earlier, it can also disrupt these developing neurotransmitter systems. What we have seen is that it can disrupt tyrosine hydroxylase activity. And this is really important because it is the rate-limiting enzyme for dopamine synthesis. And as you may or may not know, dopamine synthesis is critical for proper functioning of our reward pathways. So it tells our bodies, this was a good decision, this was and the executive functioning. So good decision, not so good decision, or I do this, I get this reward. If I don't do this, I don't get that consequence. And so this is a really important developmental function for that reward pathway. It can also alter the precursors for the expression of opioid and serotonin receptors. And we're all aware of serotonin being a key neurotransmitter for conditions like depression, anxiety, other mental health disorders or conditions that we have. And so we want to make sure that we're keeping the system really as healthy as we can throughout its entire development. And we know that this cannabis exposure during pregnancy could create some alterations in that development. Now, when it comes to CBD in pregnancy, we're at a loss at this current time. We really don't have any comprehensive research studying the effects of CBD on the developing fetus, mother, or breastfed baby. We know that high doses of CBD in pregnant test animals have caused problems in the reproductive system, especially in male fetuses. And I think if we think about CBD products being so readily available over the counter at gas stations and pharmacies, even at CBD stores, there is a potential for those products to be contaminated with substances that may be of risk, especially THC. Many studies that have been done looking at the labeling and content of various CBD products have shown us that what's on the label may not be what's in the bottle. And I think that's kind of an important takeaway as we talk to patients about the products that they're using. And it's really only with the CBD product that's FDA approved do we know for certain that CBD content is accurate. And then we know from these products that there are known risks of CBD, including liver toxicity, extreme sleepiness, and drug interactions. And so there are some inherent risks, even without having all of that information regarding CBD, to say, well, maybe it's not such a great idea. It may not be the right time for use. So what would I then say to this patient regarding the effect that cannabis could have? Well, I could say that cannabis contains nearly 500 chemicals, over 100 of them being cannabinoids, including THC. We know because of its lipophilicity that it can readily pass through the placenta and through the breast milk. And we know now that exogenous cannabis, especially with THC, has the potential to impact the development of this growing endocannabinoid system. Now, I haven't quite gotten to this yet because we're going to get to it in these studies, but I'm going to give you a little clue in here that the good news is this is not a thalidomide tragedy. We haven't seen so far any really severe congenital anomalies, missing arms, legs, any malformations from a physical sense. But what we do see is that because of the timing and the potential alterations of this endocannabinoid system, we can see effects that come into play much later, and specifically throughout adolescence, as this endocannabinoid system is so critical for many of the functions that are developing in adolescence. We see alterations at that time. And so that becomes a critical factor, I think, in this discussion, is that there may not be anything that we see immediately, but the data now are telling us that there may be something that comes later that we should be more concerned about. So that then leads us to talking a little bit more about the studies. And so we're going to go through a series of fairly recent studies, but know that, not only are these studies coming much more quickly, we actually now have, I think, an improved amount of data available. It's not perfect. The studies aren't done perfect. I'm going to address these limitations. But when someone says, well, there's no data about that, I kind of say, well, there actually is. You may not like what the data is telling you, but there are data available. And I think that's one of the things that we're gaining more and more appreciation of, especially over the last 3 to 5 years. So I'm going to start with a population-based retrospective cohort study that was done back in 2000 or published in 2019. These were people that were 15 years and older in Canada. It was self-reported cannabis exposure in pregnancy. And what they did was take a look at unmatched and matched cohorts, keeping in mind that unmatched is just kind of anyone who came into the study. When we match the cohort, that means that we have paired women kind of side by side based on similar demographics, economic status, maybe use of cannabis, things like that. Their primary outcome was preterm birth. And so I'll be showing you the results of that. But they did also look at 10 secondary outcomes, including small for gestational age, placental abruption, transfer to the NICU, and 5-minute APGAR scores. So when we looked at the preterm birth and the unmatched cohort, you can see that cannabis users were nearly 2 times as likely to have a preterm birth. From at 12%, where non-users, their rate of preterm birth was 6%. Now, when they matched the women in similar cohorts or similar groups, there was still a statistically significantly increased risk. It was about a 40% increased risk that cannabis users, you're seeing there in the blue, would have a higher preterm birth rate. This is one indicator that preterm birth might be something that could happen with cannabis users. Some limitations here is that we know that it's based on self-report. And, you know, if I asked you what you ate for breakfast 2 days ago, you may or may not remember that, much less, you know, when you were pregnant, what was the amount of marijuana you were using or did you use while you were pregnant? So that there is always going to be some limitation with self-report and the misclassification of someone. We were unable in this study to validate the urine toxicology screening. They didn't have really detailed information about the frequency, trimester, or duration of use. And, you know, like I mentioned, the cohort was matched, which is really helpful, but residual confounding can always occur in studies like this because there may be unmeasured or unknown factors that were not accounted for. In another study, this was a population-based retrospective cohort study. This was done from a very large sample in the United States. And in this case, mothers were reporting cannabis dependence or abuse. And what they looked at in this study was the association between cannabis use and pregnancy and adverse either maternal outcomes, meaning outcomes for the mother, or neonatal outcomes for the baby. And keep in mind that this is a cohort of over 12 million patients, so it's a pretty large cohort. This is looking at the maternal outcomes for these women. And so what we see here is, I'll just kind of take you through the slide. On the left side is the outcome. So you can see the pregnancy outcome for the mom and the length of stay in the hospital. You know, the 12 million or so that did not use cannabis, and then the 67,000 that reported use of cannabis. Then it takes you to a crude odds ratio, which I'm not going to focus on right now. That's just everyone kind of in the mix. And then the adjusted odds ratio, again, is adjusted for specific demographic factors, socioeconomic factors. And what we really care about is this p-value. And anytime a p-value is less than 0.05, it's indicating to us that there is a difference between the two groups. And so you can see here when comparing, there was a significant difference between the groups for all of these outcomes. And in fact, there was also a longer length of stay in the hospital for women that were cannabis users. When we look at neonates and the baby outcomes, here we're looking at preterm birth, intrauterine growth restriction, and intrauterine fetal demise. You can see here by the adjusted odds ratio that it's actually higher in the cannabis user group for all three of these outcomes with a p-value of less than 0.0001. And so these factors would be important to consider when we have cannabis users that are pregnant. What are some limitations here? Well, these women were reporting dependence or abuse, and they also found in this cohort that they were of lower income, more likely to smoke tobacco, drink alcohol, and use illicit drugs. And so these are inherently associated with adverse outcomes. So there could be potential confounding. Now remember, in that adjusted odds ratio, they do try to account for these factors. And so that's why that number is a bit more meaningful than the crude odds ratio, because in the adjusted odds ratio, they are trying to account for any of these other influences. In this study, it was also self-report and recall bias. It was likely moderate to heavy users of cannabis, not occasional users. And these are looking at very short-term outcomes, you know, kind of really in that hospital stay or that birth outcome, not years later. In this retrospective cohort study, this was young women with singleton pregnancies. And in this case, they were able to use urine toxicology or self-report for the marijuana detection. And you can see here that they had a primary outcome, which was a composite of a variety of outcomes. So preterm birth, hypertensive disorders of pregnancy, stillbirth, and small for gestational age. And what Rodriguez and his investigators found is that this composite of all four of these outcomes was statistically significantly higher in the cannabis user group. So when they kind of rolled up all four of these outcomes, 46% occurrence cannabis group, 34% approximately in the non-cannabis group. Now, when you look across these outcomes, it wasn't the preterm birth or the hypertensive disorders that was really driving that difference. The difference that we see in the composite outcome really comes from the small for gestational age, where that difference was statistically significantly different. And so just something to kind of keep an eye on as you're reviewing these studies, and keeping a perspective on, well, what is it that would really be driving an outcome like this when they're kind of rolling outcomes together? I'll just make a note here that when marijuana exposure was only defined by self-report, the association became non-significant. And this is just a nice reminder for us that self-report is not it's not that it's not reliable. It certainly is not as reliable as something like urine toxicology, because then we know that we are classifying the participants appropriately. So for limitations here, we've talked a little bit already about the potential confounding. The urine toxicology may actually present to us a higher risk group of women because they have heavier use or longer duration of exposure. The urine toxicology may not be sensitive enough to detect marijuana through passive or secondhand smoke, and we have very little data on secondhand smoke and pregnancy. We're unable to determine the quantity or timing of that use, and we also, again, have short-term outcomes here. Now, this is probably the most recent addition that I think is really interesting, that alludes to some of the data that we were discussing before. This is known as the adolescent or the ABCD study. This data is collected over several years. It's actually, this particular publication that I'm showing you is one of many that are getting published, because they're really looking at a variety of different outcomes with a large cohort of children. So for this particular study, they're looking at women that did not expose their in their pregnancy to cannabis, the fetus to cannabis. That's about 10,000. And then there was a group that they looked at that had exposure of cannabis prior to their knowledge of pregnancy, and then another over 200 with exposure after their knowledge of pregnancy. And what they tried to do was test whether or not that cannabis exposure before or after maternal knowledge of pregnancy was associated with a form of psychopathology, which was several different problems, internalizing problems, externalizing problems, attention, thought, social problems, as well as psychotic-like experiences, or PLEs. They looked at sleep, cognition, birth weight, premature birth, and gross brain structure as well. So I'm just going to show you a series of the outcomes that they found with this kind of really somewhat unique analysis. So you can see here, I'm just going to kind of talk you through one of these graphs, and then you'll understand the pattern for the others. On the left here, we have the schematic for psychotic-like experiences. So that's what you're seeing on the y-axis. Across the x-axis, you're seeing here the the unexposed group, and then those that were exposed before knowledge of pregnancy, and those that were exposed post knowledge of pregnancy. And probably because the numbers are so low, they didn't see a statistically significant difference here. However, when they look at other psychopathology outcomes, you can see that there was a significant difference with internalizing problems. So when we compare the unexposed group, this letter A up here represents a significant difference between the unexposed group and the exposed post-knowledge group. But there was also a difference between the exposed pre-knowledge group and the exposed post-knowledge group. So there was a significant difference that they saw. Again, we're looking at several years later, internalizing problems for this cohort of kids. Now, next we look at externalizing problems, and we see a very similar, statistically significantly different result, where there was more externalizing problems with the exposed post-knowledge group. We look at attention problems, a very similar outcome occurs. So again, lower risk in unexposed, higher risk, it's a significantly higher risk in the exposed pre-knowledge as well as exposed post-knowledge groups. Same thing with thought problems and social problems. And so I think you can see here the development of the potential issues that may have come from being pregnant, and being exposed to cannabis, and now 9 to 10, 11, 12 years later, having some of these psychopathology issues rise to the surface. When we look at cognition, there was a significant difference in cognition between the unexposed group and post-knowledge group, where cognition was decreased. And we also saw a change in birth weight, which we have seen in some of the other studies as well. So what was concluded then from this study is that this prenatal cannabis exposure could be associated with a small elevation in risk for psychopathology during childhood. And it's really the child psychosis liability that's modestly higher among those children prenatally exposed to cannabis after knowledge of pregnancy. They also had elevated externalizing, attention, and social problems. And overall, the authors then concluded that this exposure and risks may place the offspring at increased risk for psychopathology in middle childhood. And again, these kids were anywhere between around 9, 10, 11, 12 years old. Some limitations here, again, we have some potential for bias in reporting and misclassification. The parents are giving on, information that occurred approximately 10 years earlier. There may be a reduced power due to a proportionately small number of patients that were exposed to cannabis prenatally. And we know that THC concentrations, can differ between the fetuses based on the cannabis frequency, and I would even say the potency as well. And we also don't have, certainty on the role of unmeasured confounders. So there's some limitations that we always want to acknowledge with any of these studies, but it doesn't necessarily take away from the importance of the findings of these studies. Some added limitations, as I just mentioned, for me one is cannabis potency. Cannabis potency, you're only seeing here from about 1995 through 2014, and you can see that it has grown and grown and grown. The average, here in Colorado, the average cannabis potency for THC is now anywhere from 18 to 22%. And if we look at cannabis as a drug, clearly potency could have an impact on the potential outcome during this really key developmental time. The other thing I would just say is that most of our studies have come from inhaled cannabis. Clearly, there are a variety of other formulations available of cannabis, from oral really potent dabs or waxes, tinctures, all, you name it, patches, anything, we have it. And so we just have to be clear that most of this data is coming from inhaled cannabis formulations, but may not be able to be extrapolated to other formulations depending upon what the formulation is and how it's absorbed into the body. So little bit on lactation here with cannabinoids in human milk after maternal use. There has been a more recent study. It's actually published out of our children's hospital here, looking at 54 breast milk samples. The concentrations, looking at various aspects of the cannabis, so delta-9 THC, 11-hydroxy delta-9 THC, CBD, and CBN. What they found was that the most common route was by inhalation. Most women in this study had reported at least daily marijuana use, and all cannabinoids were detected except CBN was not detected. Whether or not that's a result of the methodology or just not, probably in all reality, not having a lot of CBN in the products that were being used. So it could be either way. Delta-9 THC was detectable in a majority of the samples. And I think this is the key part here. For these samples, the THC was still detectable up to 6 days after the last reported use. So what that tells us is that the cannabis is not only going through the breast milk, but it's staying in the breast milk for an extremely long time. And there wasn't a significant association between the concentration of THC and the hours since last marijuana exposure. And they were able to kind of do a rough calculation here to say that the reduction in delta-9 THC concentration of 3% per hour after the last exposure, which can be used to estimate a half-life of about 27 hours for THC in human milk. Now keep in mind, it takes 5 half-lives for a drug to be considered to be of minimal quantity. We use that kind of as a standard across the board for medications, which means you're talking at least 5 or 6 days before a minimal quantity of THC would be detected. Now, unfortunately, in this study, because of compliance and regulation, infant plasma concentrations were not measured, but we know from other studies that infants are exposed to cannabis through the breast milk. I'm gonna, rather than going through a lot of other studies, I've given you a few others that you might be interested in if you're interested in these topics. But again, I mean, this reference list could be really, really long. And if you have a specific question or an area, I'd be happy to provide information to help you find that data if it's available. So in summary regarding the studies, evidence does not support physical abnormalities, which is a good thing. But we do know that prenatal cannabis exposure may place the offspring at risk for psychopathology in middle childhood and some other birth outcomes. Currently, we would say that pregnant women and even those of reproductive age should be discouraged from using cannabis, and they should refrain from using cannabis during pregnancy or lactation. So with that, it brings us now to our last objective, which is, okay, Laura, so I have all this information now. How would I talk to our patients about this challenge, really, and potential opportunity to really have a meaningful conversation with our patients? So if we have our same patient come in, I think the question then becomes, we have this information, what counseling should occur? Now we have a report that is readily available, publicly available. It was updated in January of this year. It's called Monitoring Health Concerns Related to Marijuana in Colorado 2020. The website is there for you as well, so you could access that at any time. It's a really kind of a cool dashboard where you can pick various topics that you're interested in learning about. For our purposes, these are all the topics that are there, but for our purposes, you might be interested in the reproductive effects of marijuana or perhaps marijuana during pregnancy and breastfeeding. And I'll walk you through a little bit of how we translate the data into a communication tool for pregnancy and breastfeeding. But please know that on this website, it's available for all of these other potential effects with marijuana in the public health realm. So we first, with this group, create evidence statements. And these evidence statements are really there to help us understand two key things. One is a potential outcome, and another is the amount of evidence that's available. So you can see here, we've weighted the evidence and have said there's no substantial evidence to talk about effects on the exposed offspring. There is some moderate evidence that tells us that prenatal cannabis exposure could be associated with reduced cognitive functions and IQ scores in childhood. It also may be associated with attention problems in childhood. So this is an example of how we're combining the evidence to create something that might be helpful and meaningful for healthcare providers to understand, well, where does the evidence really lean? If there's conflicting evidence, which there's other columns for that, well, maybe that's not as a viable of a conclusion, right? If there's limited evidence, again, you're having to weigh that up. There's also biologic evidence that we've talked about. We've already discussed that here about how THC passes through the placenta and the breast milk. This gives you an example of what's available as evidence statements. And eventually, those evidence statements are turned into public health statements. And in this case, we've also translated that now into, I think, 2 really great documents around patients, which is called Marijuana and Your Baby. This is a handout that you can give to your patients. It goes through really common Q&A questions. It puts it in 8th grade or below for accessible reading. And it's available in, I want to say, up to 20 languages. So they've really done a nice job helping spread the accessibility and opportunity for people to get information about marijuana and breastfeeding. Now, the one on the right is geared more towards healthcare providers. So you may be interested in that. It goes through, how would you do screening questions? How would you respond to tricky questions like, do I have to report this to Child Protection Services? And so these are resources that are readily available for you at your fingertips, and happy to share as much as you need. There are some other position statements that I think you may be interested in knowing. For example, the Nurse Practitioners and Women's Health Organization has a position statement who's, suggesting ask women if they're using it as part of your routine substance use screening. Counsel them that they should try to avoid or discontinue use of marijuana while pregnant. It should not be recommended as a treatment. We have a lot of options for treatment. Women should be supported in abstaining or decreasing their use during pregnancy, and really trying to create a meaningful, non-judgmental, supportive relationship to foster a good conversation between you and your patient. The Center for Disease Control has a statement specifically regarding breastfeeding. They talk about the passage of harmful chemicals through the breast milk, or they even mention secondhand smoke exposure. And to limit that risk, patients should be advised not to use marijuana products. And they specifically call out here CBD in any form while breastfeeding as well. Other position statements have come from ACOG, the National Association of Neonatal Nurses, all pretty much saying the same thing in terms of let's screen for use. Let's talk about why they might be using. Let's talk about how we might avoid or discontinue that use if possible, and find an alternative solution that could really be helpful for them. So at this point, marijuana use is discouraged. And the way that I put this into my language for patient interactions is I tell them, right now, we don't know of any benefits of marijuana use during pregnancy. Now, that is a very different conversation when we talk about other medical conditions. But in pregnancy, we don't know of any medical benefit. There are possible risks. And for this reasons, we're advising you not to use it because there is no known safe amount of marijuana in pregnancy, similar to how there is no known safe amount of alcohol in pregnancy. So for that reason, we really should be supporting women in abstaining from or decreasing that use, and try to go to other evidence-based alternatives until we have more information. So in conclusion for the webinar, and I'll be able to get to your questions, which I'm really excited to do, we know that there can be a supraphysiologic effect on the endocannabinoid system, and this really creates a potential for meaningful, significant changes in fetal growth and development. There's insufficient evidence right now to link cannabis with a specific congenital anomaly, but we do have evidence that shows association of cannabis use and pregnancy could be concerning. For that reason, pregnant or breastfeeding women should avoid using cannabis, and we should really be trying as best as we can to promote that open, person-centered communication about cannabis with pregnant and lactating women. So with that, a huge thank you to all of you for joining. I'm going to stop my screen share. Yep, there we go. And I'm back.
Dr. Borgelt, thank you for that very comprehensive presentation. Even though I'm not a provider, I understood a lot of it. So thank you for that.
Awesome. That's what we aim to do. You have to bring it to the level that people are at, no matter where they're at.
Perfect. So we have a couple of questions. One may have been answered in the chat, but I do have a question from Alec Hirschman, and he writes, a range of interesting correlations that show cannabis on the scene of developmental disorders. So he actually has, this is actually a two-part question. The first question is there any indication that cannabis is causing negative health outcomes? And if so, by what pathways? We talked a little bit about that. And then the second question is, couldn't cannabis presence in these correspondences represent partially improved outcomes over more dramatically dysfunctional outcomes if the mothers in these studies have chosen not to medicate?
Alec, this is really insightful. Let me take question number one first, and I'll get to question number two. For question number one, I hopefully described for you some of the potential pathways. There certainly are others because the endogenous endocannabinoid system is so key in developmental processes. And I think that when we look at how we look at all that data, I tried to highlight for you the most significant ones for pregnancy and potentially development. But keep in mind that the endocannabinoid system is a system that's constantly altering and changing and responding through our entire life. I mean, the system doesn't go away. It's just that there are key developmental factors for how things may get processed later on. And so I think I hopefully have highlighted that piece of it. But the question you're asking in the second part of the question is really, really interesting. And quite honestly, one of the more difficult challenges that I have in patient care, because when I look, let me just take the example that is fairly recent. You've got a mother who could be susceptible to postpartum depression. And she's really feels that marijuana helps her while she, and because of that, she would like to use while she is breastfeeding. And so the question then becomes, well, might the outcome of a mother's untreated postpartum depression be worse? We'll call it untreated, but we recognize there might be other things to use. Untreated postpartum depression could result in a worse outcome than any exposure to the infant. And I think that's a really insightful question. And the answer is, I don't know. What I do know is that for postpartum depression, we have good FDA-approved treatments that can be effective, and we understand better what the impact could be to the baby during lactation. So if you take an SSRI, and so if you're going to choose an SSRI, you pick one like Zoloft, for example, which is probably the preferred SSRI in postpartum depression because of its characteristics in breastfeeding. And that's just one example, but I hope that's getting to your question, because I think you highlight a really important question that we're all asking ourselves is the impact that could result from use during pregnancy or this vulnerable time worse than what might happen if the woman wasn't using it? And in all honesty, we don't know. All I can say is that I know because there's risk, and I don't know that there's benefit in this time. I'm erring on the side of not a good idea. And let's see if we can find another alternative. And so I think you bring up a good ethical and really pragmatic question when we look at patient care.
Dr. Borgelt, the question that we had queued up, the person said it didn't necessarily need to be answered because it was answered in the chat. But actually, I do have a question. Given that during your presentation, you highlighted the fact that in terms of, and correct me if I'm wrong, but in terms of longitudinal studies and the impact of cannabis on pregnant women, there's still obviously some research and studies that need to take place. But just from a very practical sort of, and this is based on my work, as I'm speaking to community members during our outreach efforts, what can I say sort of in layman's terms as to why cannabis use during pregnancy probably just isn't a good idea, and something that's relatable to the layperson who may not necessarily be familiar with the medical implications of it?
This is great. And what I typically say, because most people understand that during pregnancy, there's a lot of development happening, organ development, including brain development. And I really focus on the brain because that's where we have the most information. And because we focus on the brain, we say, we know that brains are developing during pregnancy. We know that for a brain to properly develop, there are a lot of systems that are talking to each other. For example, the central nervous system. Almost everyone has heard of the central nervous system. They can kind of get their head around that. There is a parallel system that you may or may not be aware of called the endogenous cannabinoid system. And this is a system that regulates our body much like the CNS does. That's where THC works. And because it is so potent and outside the realm of what our body should be doing, it can have a negative impact on that brain development. And I frame it something like that, because I think you can't get into necessarily you have to say endocannabinoid system, unfortunately, because that's what it is. But once you get past that piece, you can kind of simplify it a little bit by just talking about the brain developing and how critical it is for these systems to be communicating together and appropriately.
Well, I don't see any other questions in, oh, well, I stand corrected.
Can I just, I do see one I want to address it. I don't necessarily need to know the specifics, but there was a question about, are there any registries that we could contribute to? And what I would say is potentially yes, depending upon the product or products that someone is using. The FDA is really, really interested in particular in CBD. And I think they're particularly interested in that because they have an FDA approved product. Epidiolex is the CBD formulation that's used in rare seizure disorders. And so depending upon product, and I would even say just you could offer that as part of our normal reporting in the FDA systems for, you know, getting birth and, you know, any outcomes that you may see. And so I think I would encourage you to put it in there. They can always take it out, but the more data we have, the better informed we're going to be. And I saw another question here about acquiring meconium for drug screens. We're not doing that regularly. In fact, I would say for the most part, we've just done away with drug screens on marijuana use. But meconium and hair are two better ways of assessing cannabis use if you're interested in doing that. Those are two viable pathways that may give you more detailed information about the duration of use and how much was used, more so than a urine toxicology, and certainly more so than a self-report. Looks like there's maybe one more question about the father's use of marijuana affect the fetus with conception. I get this question all the time, and we've looked at this. If you go into the reproductive effects portion of that evidence report that I shared earlier, you'll find a lot more detail. Right now, the data look very mixed. There are some data leaning maybe towards a limited evidence that chronic marijuana use in particular, we don't have data on occasional, but chronic marijuana use may affect the sperm. I'll just call it viability because it's kind of in several different categories of that. But I would suggest going to that, but there's limited evidence that there may be some impact there.
Looks like there is.
Oh, I've got one more.
Question.
Yep.
Mm-hmm.
Have there been studies comparing the use of SSRIs, I think is what you meant, versus marijuana and their effects? And to my knowledge, no, not for something like postpartum depression anyway. I think they're wanting to do more of that in adults with depression or anxiety. And I've seen some protocols or potential trials. I just haven't seen any results yet. And quite honestly, for this presentation, I was focused more on the pregnancy and lactation piece, but I would say keep an eye out because those are the kind of data that we'll be looking for. I don't know if they'll ever be set up head to head per se, but what they will be able to say is probably based on self-reports and knowledge of prescription use of medications. We'll be able to get a better clue as to what is effective and what's not effective.
Well, I don't see any more questions. Someone please let me know if I'm missing any additional questions. Hearing none, Dr. Laura Borgelt, I want to thank you for once again gracing us in this space. It's a very comprehensive presentation. I do want to let the folks who are still joining us that we actually have another webinar scheduled for this coming Thursday, August 26th at 12 p.m. Eastern Standard Time, where the topic will be a community provisioning center's insight, aiding veterans with medical cannabis and CBD. And our speaker will be Tisha Montague, who's the Director of Operations at Huron View Provisioning Center. And so you want to be on the lookout for that, and we'll send out a reminder within the next 24 hours. So with that, I'd like to thank everyone for joining. And once again, you'll be able to see the recording once it's posted to our website. Thanks, and have a great afternoon.